Thank you, Jens, and I want to thank Ivar Verschail, who was originally intended to give this part of the talk, but he was on call all night last night, so I'm stepping in and going to bat for him. So we're only going to talk about the treatment of the fracture. We're not going to talk about the treatment of the condition, and really the treatment of the condition is really where the greater focus is, but in incremental steps, managing the painful osteoporotic fracture is an important part of the discussion. All of us have mothers, daughters, wives who are going to be affected by this, and getting a greater understanding of what impact this disease is going to have on them is important. I'm not going to talk about painful, pathologic, metastatic fractures, but there are members in the audience who have extensive experience with this. So for the women in the audience and for those of us married to them or sons of them, this is a hugely important issue. There'll be over 250,000 of these new fractures this year in that sex, and doing what we can to protect them is hugely helpful. It's important to recognize that for any of the fragility fractures, whether they be hip fractures, wrist fractures, spine fractures, there's a demonstrable impact on survival. And that impact is negative, and it increases twofold your risk of death. This slide, although not scientific, it is actually accurate. This is what happens in the process of these fragility fractures. You start out with a disability, you end up in a destitution before you end up dying a painful death. And this circling the drain, so to speak, consistently happens in the non-treated patient. The great thing about registry is registry embraces the heterogeneity of the disease, so all of its clinical manifestations are welcomed into the registry, and the registry segregates the sub-cohorts who actually respond beautifully to one or another treatment. So the benefit of registry, for those of you who are not participating, be open to the notion that registry participation hugely contributes to the enlargement of this knowledge. So what we're going to do is we're going to compare non-surgical management with cement augmentation, which you could just put generically under a term vertebral augmentation. Put cement in the fracture. This is our academy position that Jens mentioned, and a recent meta-analysis by Paul Anderson that included the original articles that argued against cement augmentation, shows that there is controversy across the board in all subspecialties as to whether to do this or whether not to do this. Whether you treat these patients with cement augmentation, which is called kyphoplasty or vertebroplasty, or whether you do not and you treat them non-surgically. The cement augmentation piece comes in this form, is called kyphoplasty, where a balloon corrects the deformity and then the cement is put into the cask that the balloon creates. The balloon creates an eggshell cask into which you can inject the cement, or vertebroplasty, where you just directly inject it and don't worry about correcting the deformity. Paul's paper looked at the most recent 8 randomized clinical trials, included the Colmism Bookbinder trials, and did a meta-analysis on whether or not the patients in all of the trials benefited from the augmentation. And what was found in that meta-analysis is that pain improvement was greater with the cement treatment, that functional improvement was greater with the cement treatment, and that there was no increased risk of secondary fracture. Secondary fracture in an osteoporotic female is a very important thing because the risk is 1 out of 5 per year. So over a 5-year period of time, there's a 100% likelihood you're going to have another fragility fracture. And what was found in the meta-analysis is that there's no increase of it. I'll show some data from locally that'll augment this conversation. So when we look at the Chen article, which was out of Hopkins, and what they did is they looked at non-surgical treatment for the practical aspects of medical care. How long are they in the hospital? How often are they readmitted? And for the payer, this is a critically important question, especially in the bundled payment era. If you're having readmissions, you're having extensive healthcare utilization. More commonly, the expense arises out of three things: the length of stay, the repeated imaging, and as you saw this morning, there were multiple scans on a patient who eventually, because of her seizure medication, went to surgical treatment. What we find in the community is the patient comes into the emergency room, gets a scan, gets sent out in a brace or in non-operative treatment, comes back into the emergency room 2 to 5 weeks later for another scan. There's progression of disease, goes back into hospitalization for pain management, gets sent to a nursing home, finally comes in the third time for another scan. And the utilization revolves around multiple imaging and hospital stay and nursing home placement. And what we find when we take a look at the treatment of this, the payers are concerned about the cost. So they instituted a local coverage decision around coverage with evidence, which means they will cover it if the treating clinicians provide the evidence. And if you don't provide evidence, they will not cover it. And so what you see here is the primary focus of this is to get a baseline data on the demographics of the patients and the patient characteristic. Those characteristics are in the authorization process. And then they get data around the treatment, that's the process of care. And then lastly, they want PROs, and those PROs are on time points. So 1 month, 3 months, 6 months, so that you can compare the severity of the condition and the amount of the improvement subsequent to the treatment. So when we look at this initially in the jurisdictions that we participate in, so this is jurisdiction F out here, and it has since grown to a combination of jurisdictions E and F, but there are a lot of patients who underwent this procedure. And when you look at the list of things that you must do in order to participate in getting authorization, it's a very significant data burden for the clinician. And it's with a relatively narrow margin, profit margin, in order to conduct the practice of business of medicine. So this is a lot to do. And if you're not involved in a registry, you have to do this if you get authorization for treatment. That's a long list. It's hard to do. And essentially what the registry did was develop a checklist to allow all of these things to be accomplished so that authorization for payment would occur, and they made an agreement with Noridian, the Medicare vendor, that enrollment in the registry would guarantee that the registry was responsible for getting the PROs, the patient-reported outcomes, at 1 month, 3 months, 6 months. And the clinician did not have to do that. So it made the validity of the data greater, because now you have an independent third party who's asking the patient, did you get better, instead of the clinician's office. And you open the clinician's office to see another patient in that time slot instead of seeing a follow-up patient. So if you had a large vertebral compression fracture practice, your time slots would be entirely occupied with post-operative follow-ups, which is financially irrational, and you could not do that. So the registry satisfies reimbursement and follow-up. And the reason it's impactful is a phenomenon called clawback. What Medicare has the right to do and has the power to do and is now in the process of doing is to go to health systems or clinicians' practices and do an audit on the data you were supposed to submit because you're participating in the LCD, so you're required to submit that. And one of our colleagues down south, part of this health system, was found to be non-compliant in 24 out of 25 cases for data. Medicare put an immediate halt on all authorizations, so they cut off this practice for that facility, and they imposed a penalty. So it's very much like if you know anything about fishing, if you get a treble hook caught in your ear, it immediately focuses your attention. You don't do anything else until you get that hook out of your ear. When Medicare descends into your institution, you immediately focus on what they wish, and you don't do anything else until you accomplish. That's very disruptive. But it succeeds at getting the data. They contacted the registry, signed up, and immediately obtained 100% authorization and the umbrella guarantee that the registry will perform these follow-up data submissions on your behalf. So it freed them up to practice as they wished. And since being enrolled in the registry, their market share has increased whereas other clinicians who are not doing this as often, they're doing it even more often. And from a business perspective, they're doing it at a greater profitability. So the institution, the health system, is profoundly grateful for enrollment. But the clinicians and the community involved are profoundly benefited as well. And the ease of the practice of medicine is enhanced because these burdens are no longer yours. But they are done so that the payer gets coverage with evidence. That's what the payer wants, evidence. So this is the evidence. So this is the trends evident in 400 cases of registry. Some of these cases are from that institution I'm referencing. Some of them are from my own. And what you see is in green is the registry data. And one of the 8 randomized control trials that were used as part of Paul Anderson's meta-analysis is referenced here. I have other slides that show every single one of them in different colors, and that's a more complex slide. So this is a good summary of what happens. What you see is the right-hand slide is a pain slide, and the higher the score, the number here is from 0 to 10, and this is a number 9.1, and what that means is the patient is profoundly painful. So what you see is in the community, the pain score is higher. These people are worse off than in the large studies. And the pain improvement is greater than in the large studies showing the vertebral augmentation, which is the red line, and the non-surgical treatment, which is the blue line. The function study is right next to it, and it shows the same thing. This is a Roland Morris score. So you have 25 questions, and the more of the questions you mark positive, the higher the score. And each question asks you if you have a disability in doing this or a disability in doing that. So the higher the number, the more disabled you are. So these individuals are highly disabled. Their number is about 20. And their improvement is greater than in any other study, not only the non-surgical, but also other vertebral augmentation studies. The econometrics for the health institution, the hospital, and the practice also parallel these, but since this is a medical talk, I'm not going to show the econometrics, but the econometrics show that it is sustainable for the health system, and it's enhancing for the practice and for the local referral network.
How soon is augmentations being done? Are those acute augmentations?
You're getting to registry. What is the purpose of registry? And I'm going to hold Dave's, how quickly should you do this? I'll answer that by saying the benefit of registry is the embracing of the heterogeneity of the condition. You open the doors to everyone, whoever has it comes in, and you don't restrict in any way. When you do that, you find out those sub-cohorts, those smaller groups of patients who are ideally suited, and what are their characteristics? Are their characteristics the acute fracture in the acute period before the secondary collapse? Because in my practice, I repeat an x-ray in 1 week to prove that the conservative treatment is actively failing before your eyes. That's why I asked the question this morning of where were the original x-rays and what was the original scan, and did it show progression on that patient? Because if you prove that they're actively failing, you've established a patient characteristic, and it helps define that population. And so eventually the registry will do that. The N numbers to get to that point need to reach in the thousands, and right now they're at 400, so it's too early to say. But what you see here is these are the practical aspects of it. Number one, so here what we're looking at is we're looking at Chen's article out of Hopkins, where they're looking at non-surgical management for hospitalization, vertebral augmentation, and we've put the local community registry data right next to it. What you see is, in some of the cases, at least in my practice, this is same-day surgery. You come in the morning, you go home an hour later. And as a practice of business, I'm part of ProLiance Surgeons, so we're a large group of orthopedic surgeons up and down the I-5 corridor and across the other side of the mountains. We do surveys on every single patient who goes through our ambulatory surgery center. The highest patient satisfaction survey is not my cervical disc replacement for painful arm weakness, or my colleagues' carpal tunnel releases, although they compete for second place very actively. For the last 3 years, the highest patient survey for satisfaction is the little old lady who comes in a wheelchair, pushed by her daughter, and walks out of my ASC after one of these vertebral augmentations. And it's been that way for over 3 years. Now, that's not scientific. It's anecdotal, but it's informative. And so what you see is also the readmission rates are dramatically lower. And this is important for a payer and for a hospital system because this is your utilization cost metric. That readmission, back for another image, back for another hospital stay, for opioid complication, constipation, urinary tract infection, altered mental status, fall now with a hip fracture. Those are all very impactful consequences that show up in your readmissions. And a non-surgical study compared to a vertebral augmentation study would be most informative around those additional costs. And we're in the process of rolling that out. Because really what you're trying to do is measure the value of what you do, and that value has both medical and economic components to it. These are some of the granular metrics that help you decide from a pain perspective or from a function perspective, what are those sub-cohorts that, David, you were asking about? In what time frame should you be doing this? In what patient, what group who have what characteristics is this going to be the most successful? And so that I get you all back to work on time, I'm going to conclude to say that there are fragility fractures are associated with known consequences. And those known consequences for hip fracture, wrist fracture, vertebral compression fracture are really quite clear. And they're the 3 Ds. And they are a miserable way for a woman to spend her final years. The augmentation, both on meta-analysis and from the registry perspective, have remarkably encouraging trends. And although it's not scientific from the registry perspective at this time, so it's not blinded, it's not randomized, it's not controlled, it is insightful that such benefit occurs and patient satisfaction occurs, that it merits those of you who are doing this work to enroll in registry so the work that you do and the benefit that occurs gets tracked and added to the data set.
Fantastic. Yeah.